welcome everyone. Thank you for joining us for the Tuesday Grand Round. Today, I'm pleased and honored to introduce to you our today's speaker. Today, we are honored to have Dr. Gary Chaimowitz with us, who will discuss the risk assessment for the mental health courts. Dr. Chaimowitz is a professor of psychiatry and forensic psychiatry academic division lead at McMaster University. You're also head of service of forensic psychiatry at St. Joseph Healthcare, Hamilton. Dr. Chaimowitz had the Royal College of Physicians and Surgeons and the Forensic Psychiatry Founder States, and an MBA from the University of Toronto. And he is a certified physician executive, certifying Commission of Medical Management since 1999. Dr. Chaimowitz is a diplomat of the American College of Physicians Executive. He obtained the Chartered Director designation from the Directors College in 2022. He is a distinguished fellow of both the Canadian and the American Psychiatric Associations. He is the past president of the Canadian Psychiatric Association. He is the Canadian zone representative to the World Psychiatric Association. Continuing medical education activities include organizing the Canadian Psychiatric Association International Professional Development Conferences and the International Forensic Psychiatry Lecture Series and the Forensic Psychiatry Risk and Recovery Conference. The International Forensic Psychiatry Lecture Series is an innovative weekly lecture series broadcast every week with attendees from over 55 countries. He is the editor-in-chief of the International Journal of Risk and Recovery. Dr. Chaimowitz has been awarded the Ontario Medical Association Life Membership Award in 2022, International Association of Forensic Mental Health Service Rudiger Miller Eisberner Award in 2021, Canadian Psychiatric Association C.A. Roper's Award for Clinical Leadership in 2016, and Association of General Hospital Psychiatric Service Award in 2016, Ontario Medical Association Section Service Award in 2016, Canadian Academy of Psychiatry and the Law Bruno Cormier Award in 2015, and St. Joseph Healthcare Hamilton Mission Legacy Award in 2015. He is a member of the Ontario and Nunavut Review Board and the Forensic Psychiatry Specialty Examination Committee at the Royal College of Physicians and Surgeons of Canada. He is a member of multiple committees and co-chair of the Lancet Psychiatry Commission on Mental Health. He has been actively involved with the American Academy of Psychiatry and the Law, have written editorial for the journal, been on council, and is an active member of several committees. He was chair of the Royal College of Physicians and Surgeons Committee that launched forensic psychiatry as a subspecialty status in Canada. Other past positions include president of St. Joseph Healthcare Medical Staff Association, chair Ontario Medical Association Physician Section, president of Ontario Psychiatric Association, chair the Canadian Psychiatric Association Professional Standards and Practice Committee, vice chair Consent and Capacity Board, chair Royal College of Physicians and Surgeons Forensic Psychiatry Specialty Committee, and council of the American Academy of Psychiatry and the Law, co-chair Forensic Directors Group of Ontario and board of the International Association of Forensic Mental Health. Dr. Chaimowitz, thank you for accepting the invitation. It's an honor for us. Ladies and gentlemen, please join me and welcome Dr. Chaimowitz. Dr. Chaimowitz, the floor is yours.
Thank you very much for that kind introduction. Guys, I'm really great to be here. As I said earlier on, I'm bilingual, but my second language is not French, so I apologize in advance for that. I'm going to talk to you a little bit about risk assessment and some guidance for preparing for the review board. But just to let me see if I can just move my slides along. Just to let you know that I am speaking from the traditional territories of the Erie Neutral Huron-Wendat, Haudenosaunee, and Mississaugas, and the land on is governed by the Dish with One Spoon Wampum Covenant, which is an agreement between the Haudenosaunee and the Anishinaabe to share the resources around the Great Lakes. And Hamilton, where I am right now, is home to actually many Indigenous communities. And I think it's contingent upon myself to try and continue to understand, where I am and our different roles here in Untitled Island. Okay, so I've no disclosures. Just a bit of the objectives. I think you understand. I'm going to talk a bit about risk assessment. I'm going to move through my slides fairly quickly, but because I want to focus on a few key risk issues and then talk a little bit about the review board. But just one of the things I did, so it's a bit of a shameless plug. I'm not plugging an article that I wrote, but someone mentioned the International Forensic Psychiatry lecture series, which we've been running for, I think it's 4 or 5 years now. It's every Thursday from 10 to 11. It's 45 minutes and 15 minutes Q&A. If you're interested in forensic type issues or risk type issues, these talks are from people from all around the world. It's broadcast, as you heard, to 55 to 60 countries. So we have many participants. And it is also cataloged, so you can go back and look at things that may be relevant and important to you. And so we can always get you on the list. Certainly, if you're interested in forensic type topics, this is considered one of the better offerings. And of course, I'm somewhat biased. I'm going to talk to you a little bit about risk assessment and risk reduction in the mental health courts, but I want to talk to you first about risk assessment. So what is risk assessment? For many of us, it really is figuring how not to get hurt yourself and making sure that others don't get hurt. I know that many of you work in different settings, but I think one of the things I do want to point out before I start talking about risk, because risk does label our patients, I think the important thing is to remember that the people that we are assessing, whether they be inpatients or outpatients, are often people who are going through the worst periods in their lives. But some of their behaviors, which is sort of driven by often the psychosis, drugs or alcohol. But on top of that, these are people who are really struggling. And if you think about the worst periods in your life, you're probably not at your best. You're not at your best. And it's really important, in my view, that we don't judge the person, but rather understand the illness. And it's the same for outpatients. The interesting thing, obviously, about outpatients and the irony in our risk assessment process is that even though it sometimes feels more risky to be looking after an inpatient, in terms of understanding risk, it's often much harder with outpatients because you have way less collateral information and you're really not aware of the many hours or days these individuals spent interacting with the world, and you have no control over that. So a lot of unexpected things when it comes to managing outpatients. So it is a risky environment. There's an expectation that we in our jobs do risk assessment and risk management, and many of you will be aware of the Canadian, of Tarasoff from the US, but specifically Smith Jones. So not only are we mandated in many of our jobs to look and assess risk, but we are also obliged by the courts. In other words, if we fail to look at risk, we put ourselves in jeopardy from the courts. So, in my view, with a little bit of understanding about risk, it can go a long way in protecting you, your patients, and also help guiding the courts. One of the things that I've thought of over the years, having focused a lot of my time and thinking about risk, is that risk really is a function of variation. So it's when things change in the environment or with the patient that I think you need to become more alert. So you look at many of the risk assessment protocols, it's not just the assessing of static risk, but there's dynamic factors. And when things start changing with your patients, that's when you need to lean in. Before talking about risk, and I used to do this at the end of the talk, but I'll do some then as well. But I do want to talk about risk prevention because, especially in the forensic world, you don't want to just be scared of somebody and blame them. But if we as a population can think of the things that can improve danger or like reduce dangerousness in the community, these are some of the things that I think we as individuals and Canadians need to think about, which is making sure people are educated, the social determinants of health are put in place. Kindness goes a long, long way. Good governance with responsibility to attend to some of these things. And some of the other ideas that, if you treat your patients as you wish to be treated and people treat each other that way, we can go a long way in creating a much safer society. I also am a strong believer in the butterfly effect. Every little thing that you do, every single act of kindness multiplies every time you do it. And I think, again, also to recognize that we'll never get rid of risk. The hope is that we can just shift the dial a little bit, change the chances for the person in front of us, even if it's just a little bit. Okay, so I want to go through some definitions, and some of the things I think are really important to think about is to break down risk. And if I was walking in the room with you, I'd ask you what some of these things are. So what is risk assessment? So why don't you just think about what is risk assessment, and I'll give you a definition, because risk assessment is the systematic collection of information to determine what chance there is of some harm coming at some point in the future. But there are 4 of these definitions. The next one is risk prediction. So risk prediction is, once you've collected that data, is now assigning a probability to the person, indexing the likelihood of that behavior occurring at some point in the future. So you see, when you talk about risk, it is broken down, and there's some more definitions. The other one is risk management, and often we are tasked with risk management. There's an expectation that we can manage risk. So risk management, when it comes to looking after the patients that you care for, is that putting in all those sort of operational procedures and supports that are dynamic and are sensitive to that person's specific needs, vulnerabilities, and changing behaviors. And that's basically to create a safe, sound environment with all the supports in place. But we go beyond that, or should go beyond that, because not only do we want to do risk management, but we want to do risk mitigation or even risk prevention. So it's all very well managing your patient, putting those supports surrounding your patients. But really what's critical is to see if you can provide the resources to the individual where they are able to change, the intrinsic factors change, and ultimately the risk is managed because the person has changed, not because we've got controls. So people again think about risk, and they think, oh, risk is risk assessment. But risk is not just assessment. It's collecting the data. If you don't know how to collect the data, you're not going to be able to do risk prediction, which is what's the likelihood. If you don't know what the likelihood is, you're not going to be able to provide management. And then ultimately, once you're managing the patient, you want to actually be able to ensure that the person has within them the sorts of skills where they are able to manage risk. So I think it's really important to remember it's broken down, in my view, into those 4 categories. Just to remind those of you, many of you may know this, that there have been various generations of risk assessment. The first was clinical judgment. That's not evidence-based psychiatry, that's eminence-based. I'm a professor, I know better. I've known this patient for many years. In my view, it's blah, blah, blah. And that's been shown that that's not as accurate. There was probably now 30 years ago, a group of very, very smart psychologists who created some actuarial tools where they plugged in information about the patient and produced a likelihood of that person being violent in whatever the time is, 7 or 10 years out. But it didn't account for all the dynamic factors, the changing clinical status of the patient and so on. So in a typical Canadian fashion, some of the top researchers in Canada came up with something called structured professional judgment, which incorporates evidence-based factors, but also allowed for some clinical input. And in fact, that was the state of the art for a long time. We've gone beyond that, where we've also realized that we as individuals don't practice in isolation, we practice in teams. And there's some pretty good information to suggest that team-based risk assessment, in other words, where there are more than one person inputting, will always be better than the individual. And you know, so you should, as much as possible, think about risk and risk assessment done in a team-based setting with multiple inputs. And also where we are right now, and we're at the cutting edge of this, is using the 5th generation machine learning, big data, to see if we can predict risk using some of those factors attached to patients, because we have the capacity now to put that in to an algorithm and make some predictions about managing risk that way. Okay. I wanted to say a couple of things just about risk in general. So you know, you're doing a risk assessment. I know many of you are focused because you've got to write a report for the tribunal or the mental health courts. But really, you want to live in a safe environment, both on the units, the community, and you also want to identify treatment needs. But again, risk assessment allows you to provide advice to the mental health court, but also allows you to figure out what sort of monitoring the person needs and what sort of rehabilitation levels that person should engage in. It is important, I mentioned this before, there's no such thing as zero risk. There will always be risk. Right, so if I asked you, I mean, the risk of each one of you killing somebody in the next 24 hours is probably close to zero, but it's not zero. I mean, especially if I agitate you, you know, you might get annoyed with your neighbor, but it's not zero. It's just very, very low. And with many of our patients, we'll never get to the point of zero risk. Certainly for the tribunals, you want to get below a threshold of significant risk. So there will always be some risk with our patients of doing something all of the time, but what you want to do is drop the threshold. So if you're shooting for zero risk, you're not going to get there. Another thing to think about is risk is dynamic. The assessment yesterday is not the assessment today. Somebody who's got a borderline personality disorder may have a life crisis, and whatever you've said about the person before might change because of something that's happened. Your patient who you assessed in the morning might have used drugs at lunchtime, and the risk is different in the evening. The other thing is you have to think about the type of risk and where it's targeted. So risk could be general, be very specific to a particular person or people, or it could be both. I said as well that risk can't be done in isolation. One of the themes that's really important is to think about the fact or understand that the biggest risk is not taking a risk at all. If you want to sleep at night, you can lock the units down, put the people in hospital, put people in jail, whatever it is, and go home. What we need to do is look at carefully titrated access to the community. So it takes some risk with the patient, which has got to be thought out. As I mentioned with Smith-Jones, we have an obligation to manage risk if we see it. Another important thing that I think is an important takeaway are the different facets of risk. So I would ask you, what are the different facets of risk? And here's some of the ideas. And I say this because sometimes when you sit in a team meeting, somebody will say this person's high risk. Question is, of what? So what kind of violence are we talking about? Are we talking about a slap, punch, a stabbing, a murder? Is it sexual? How severe is it going to be? What's the consequence of that particular act on the individual that's targeted? How often is it going to occur? What's the frequency of this? Is it once a month? Is it every time you see them? Is it every 5 years? And the immediacy, which is, and this is the thing for the clinical units, is it going to happen today? Or is it going to happen in 6 months or a year? Context. And I say that because for some people, it is only when they use a particular drug or drugs. There's some people who are absolutely fabulous. And the number of times I've heard from some of the people I've seen, I'm totally fine. I drink alcohol and I'm an instant asshole. They'll tell me that. So it's specifically context. And there are also people with IPV. It's only in a situation with intimate partners that the risk is there. But if you're looking for a simple formula to think about risk, here are some of the two more or most important factors in thinking about it. Think of this as a little formula. So risk is likelihood by magnitude. So you multiply the likelihood by the magnitude. So the frequency by the severity. So if it's a punch every 6 months or every month, it's probably lower risk. But a punch every time you see the patient, so the frequency is much greater, the risk is greater. For something like a murder, if it's every 5 years, it's because of the gravity or severity. You multiply that two, and then you think that is high risk. So you need to think about those two things and think of it as a multiplication, i.e., somebody spits in your face or in your eye every time you see them. It's a spit, but it's every time you see them, you consider that risk greater. Okay, a couple of other issues, but we will talk about the tribunals shortly. I want to give you sort of a sense of risk as I see it. And depending on your settings, and I don't know all of your settings, you also have to be nimble in assessing risk. So when you look at all the risk assessment instruments that are out there and people talk about risk, they talk about understanding risk over a period of time. What's the likelihood in a year, 3 years, 5 years, 7 years, 10 years? There are different tools. The problem for most of us as clinicians, it doesn't help the nursing staff and us on the unit at that day. So there are very few tools that are available to help clinicians deal with risk every single day. I don't care what the risk is in 6 months, in a year, or whatever it is, what's happening today. So we as clinicians have to be nimble about this. And so the question for many of us is, how do you integrate that into a team meeting and a monitoring? The other thing that's really important is, how do you talk about risk in an informed fashion rather than being somewhat arbitrary? I'll talk a little bit about how that can go wrong. You presumably have team meetings. This is the rock face of talking about risk. When I started looking at this, I won't tell you how many years ago, decades ago, we had a psychology PhD student sit in our team meetings, and we asked them to calculate and record how many times we spoke about risk for patients in an informed fashion. And it turned out it was very, very low. It was much easier to talk about splitting bowel habits, passes, and so on, than talk about risk, because it is a little bit more of a highly charged situation. So this is a non-issues, and also that sort of idea that you can talk about just about anything except risk. Okay. Couple of issues just to recognize that we have some problems with the aging population. I worry about who's going to look after me when I start punching people out, and other things. Another just an important point, many of us will use families and collaterals as deputies for us in the community. I would say it is very, very hard to do that. And what we do know is that families have a lot of difficulty seeing their family members as anything but family members. So it's very, very hard to see risk issues when you're dealing with your own family. So it's very hard to kind of get those guys involved. I'll also say, don't ever underestimate the benefits of getting a second opinion. It's hard to call risk. When 2 or 3 of you are saying the same things, you're in a much better place. Okay. Inpatient settings, risk is often not dealt with, but I want to talk about a couple of pitfalls as well. So when it comes to forensic patients, and when you start doing risk assessments, so you get psychology to do risk assessments, what you're probably going to do is you're going to get a sense that most of our patients are moderate to moderate high risk. So what is it? How does that in fact help us? And what does that actually mean to us in a real sense? So, as I say, of the 120 patients in our inpatient units, I'd say most of them are moderate to moderate high on all psychological testing. And the question is, does that help us anyway? The other thing, and it's the same issue that faces many of us when somebody asks us to assess somebody for a murder or a school shootings, or someone's threatening kids in school, it is almost impossible to predict, I would say it is impossible to predict that type of violence. So rare events are incredibly difficult to predict. Clearly, somebody's going to have seen a patient before they go out and murder somebody. The person that went into the movie theater and shot up people in the US, seen a psychiatrist just before. And that poor person, one of those random things. So it's very, very difficult to predict that sort of violence. And again, sometimes, we do something and nothing bad happens, and we think it was actually a good thing we did. Low base rate things, it's very, very, very difficult to actually know whether it was our intervention that changed things. There are some hospitals that actually will put on the charts, this person is violent. I got to tell you, those things are very arbitrary, that don't account for change, and they are quite stigmatizing. I'll say one other thing about that's a checklist. And many organizations and many leaders will want staff to do things. It's really important that the pilot that flies your plane does a checklist before they take off. Is there fuel? Have they walked around? In fact, even on the big planes that you go on, they will go through a checklist, because they know if you don't go through a checklist, you might miss stuff. I know when I was trying to get my private pilot's license, they would ask us, how do you look for another plane coming at you? Because planes would collide in midair, like head on. And the truth is, when you look at something out there, unless you actually turn your brain to say, I need to look at these spaces. So they would force us to look in upper left quadrant, no plane, upper right quadrant, no plane, and so on. And then all of a sudden you might see something. But if you're looking out in the sky, your brain sometimes doesn't pick up something coming at you. So checklists are useful, but they are not the be all and end all. So they have a benefit, but they also have a downside. A couple of the other little, I'd say these pearls. One of the things it's really puzzled me, because I've testified at inquests about this stuff. I've looked at files, done a whole bunch of medical legal reviews about outcomes, looking at charts. And given the concern that people have about violence, it is always surprising to me that people who are concerned about aggression and violence on inpatient units or anywhere don't actually measure them. So I'll show you how we can do this. Just two slides on team meetings. Many of you work in team meetings. You can look at the slide. This is just about meetings in general. I think there's an incredible, you have to be very clear about language in team meetings, and we know we can do this. So if you walk into a team meeting, you're about to discuss your patient, and a nurse comes or somebody comes in and says, oh my God, this person did something really, really terrible yesterday. They threatened someone, smashed a chair, against someone's head. The person was hospitalized. And then they say, oh, that's the wrong patient. I was thinking about somebody else. The problem is that creates a bias against the patient you talk about. So it's very, very important the details about your patients are accurate, and that people don't speculate or misrepresent the patient, because it skews what your thinking is going to be about how to manage the patient. I'm going to go on to talk about preparing for the review boards, but I just want to show you one of the things that we've developed here. This is a tool used internationally. We think it's the best out there in terms of measuring aggressive incidents. It tracks aggressive incidents on the units. It's very easy to use. We can always send this to you. It's incorporated into our team meetings. So we measure every aggressive incident in our inpatients and outpatients. There's all sorts of aggression, sexual aggression, physical aggression. It's a 9-point scale. Inter-rater reliability is fabulous. You can just have a sense of it. There's an escalation. We record these things, so we have real data on our patients. We also make a decision after you've recorded it, whether you intervene at all, whether it's a verbal intervention, I talk to the person, whether it's physical, such as giving them medications or moving them to a secluded space, or you call police. This is what it looks like on the documents. We put this up on the inpatient units on the patient side as well, so they know that aggressive incidents, even being rude, we consider an issue. So patients are able to even record themselves, but it also sets a tone as to what is applicable. And using something like this, if you have an intervention, obviously you can see that makes a difference. I'll just tell you about one other thing that we've developed here, and I'm not going to go into it in any detail, but we have a cloud-based risk management tool which collects about 20 to 30 factors, takes 5 or 10 minutes, projected on a screen. And it's actually, we have it in French. It's just, as I say, we've probably spent, 7 figures developing this tool over the years. It's in multiple languages, including French, but it's a 5 or 10 minute tool to manage risk on inpatient units. It does all sorts of very cool things, but not for today. Okay, so let's talk a little bit about mental health assessment for the courts and tribunals. I think the important thing when it comes to the forensic type system is that if you know the assessment to come in for not criminally responsible, put aside fitness to stand trial because there's no real exit for that one generally. But to get into a forensic psychiatry types setting, you have to be found not criminally responsible. So it's as you know, section 16(1) of the criminal code, there's a mental disorder, there's an act, and you either didn't appreciate what you were doing or you didn't know it was wrong. The exit, and this is of course why risk assessment is important, it's a different door. It's around risk. And that's why we need to think about the exit is around the risk that the person poses. It's got almost nothing to do with the criteria that got the person into the forensic system. So what are those things? So if you're looking at reports that, and I've got probably 3 or 4 slides on this that I want to just go through with you. So the key things. So remember, if you think about risk assessment, prediction, management, and mitigation, you've got to know what the offense was. What is the thing that got the person into this situation? You've got to know what the diagnoses are. You've got to know, I said index offense again there. You've got to have a sense of their criminal record and the history of violence. And nowadays in Canada, many people have been pardoned. So when you ask them about their criminal record, they may not tell you about the offenses for which they're pardoned. You do want to know about what their treatment adherence or compliance is. You do want to know about their drug and alcohol history, and you do need to know what people are using nowadays. Because many patients will not tell, some people will tell you that they don't talk about marijuana, even though marijuana is a major, major issue nowadays. And we are thinking that we need to be writing to government about the early warning signs that marijuana use is associated with psychosis, which is associated with homicide. Because we, in sort of anecdotally among our forensic leaders in Eastern Ontario, and I was just at an American meeting last week, are talking about the concern that the marijuana that people buy in the stores have negative outcomes. But you also need to know about some of the other products that people are using. Those of you that may work in corrections, there are all sorts of names for all sorts of synthetic products that are out there. Insight is really important. People write books about insight. So when you say, somebody says, does this person have insight? Well, insight into what level of insight? I always find it amazing that people in our system have so much difficulty saying the following: I have a mental disorder. I need to take treatment. I need to take treatment for the rest of my life. When I get sick, I know it is associated with aggression. I really don't want that to happen again. I feel sorry for what I've done, and I will not use drugs or alcohol, and I'll do this for the rest of my life. It's almost like a poem they can recite. But for most of our patients who are not on the outside, on the inside, for some reason, they're unable to do that. So, but when you look at insight, it really is insight into the illness, the need for treatment, the association between this and that, whether it's true insight. In fact, they can articulate something is perhaps the first step. But obviously, what you want to see is how deep that insight is. I think it is also important to think about positive factors. And there's a tool called the SAPROF that looks at positive factors. I'll show you a slide on that in a minute. Because what you want to do in terms of a report for a court is not only knowing what the risk factors, but what are the positive factors. So where can you sort of boost bolster some of the positive factors or where there are gaps, what programs people have gone to. I think one of the naive things that we do before releasing people who have substance use problems is suggest to them, or the courts, this person has or hasn't been to a substance use program. The information to suggest that substance use programs work in certain populations, I mean, they work in some people. It's down to around about 15%. There's not a lot of research on substance use programs in forensic populations. Doesn't mean they don't work, but there's not a lot of like a lot of research in that space. So we feel better sending them to programs. The tribunals and courts feel like happier if they do that. We don't know if they just sat there. Did it sink in? And even if it did sink in, is it a changing of frequency, turning that dial, or is it eliminating substance use from the picture? So I think we need a lot of work to do on the programs, but there are other programs like anger management programs to help people who programs for intimate partner difficulties, appropriate courtship, medication understanding. So all of those programs give you some of an indication of the person's commitment to getting better. And of course, treatment effectiveness, it's all very well taking medications, but it's important to know if these things work. And again, when we go to our tribunals, we often have to say to the courts, we think this person is going to become unwell again if left to their own devices. If we're able to put these things in place, like a disposition or obligatory monitoring, we can manage the risk. Left to their own devices, they're going to stop their medications, fall away from treatment, start using drugs, and become unwell again. Now, I'd say that is important in a civil system, so your Mental Health Act. But when it comes to even forensic type patients, for our side, which is a little different from the civil review boards, we also have to think about, okay, it's fine if they become a psychotic again, but will they actually become psychotic and then commit violence? Many of our patients, they'll stop their meds, they become psychotic, but not everybody commits an aggressive act. So we have to have that particular link in there, and also the link with substances, because sometimes it's the accelerant factor of using mushrooms or speed that gets the psychotic individual into a much more aggressive space. Now, there are risk assessment tools that people use, depending whether you're in the forensics or the civil system. For a small number of people, psychopathy is an issue. And the psychopathy checklist revised is the tool. You actually need some training in that. Psychologists have done that, some forensic psychiatrists. 20 items, 0, it's not there. 2, it is there. 1, it's in the middle. And the score generally over 30 gets you into the psychopathy, which is association with violence. There are actuarial tools such as the VRAG. And there is the HCR20, which is probably the gold standard, slightly whatever the most common book in the world. It's the most commonly used risk assessment tool, which is the HCR20. But there are other ones. Psychology weighs in on PAIs and MMPIs and gives you some information. So here's just a look at 2 of these tools. You can download these from the internet, or you can pay money and get the book, but they are commonly used. The HCR20, which is on the left-hand side of your screen, is divided into 10 historical factors, 5 clinical, and 5 risk management factors. And what the author of this, guy called Chris Webster, did, what he wanted people to do is look at a little bit like that checklist, look on the left, look on the right. Think about each of these factors, score them, 0, no, 2, yes, 1, maybe, and work your way down these research-supported risk factors, and then see what you come up with. So he would say, if you're going to make any assessment of risk, you've got to think about, I'm not going to read these all up because we're going to run out of time, all the historical factors, all the clinical factors, the risk management factors. You'll get a score out of 40. He said it was more a memoir, but of course, as soon as you come up with anything with a number, you're going to get some masters or PhD students kind of studying with a 20 is worse than a 10 and that sort of stuff. But if you want to go through a thoughtful consideration of your patient, going through an HCR 20 is actually a very, very good exercise because those are all the key factors. The SAPRAF I put there just to reinforce that there are protective factors out there. So when you're talking about a patient, you're not damning them with a risk score, but you're also thinking about some of the other things that you or other people or the patient can work on to see if you can improve the likelihood of an untoward event. So that's kind of the kind of an overview of this. I just want to say a couple of other things before we wrap up and take some questions. So risk is obviously an issue, but recovery is, in my view, something that we in this world should be working towards. So I think as individuals working with patients, it is a collective judgment. I do think we need to think about courage for us, for the patients, for the people that look after them and support them. And I think our decisions about risk as a collective judgment should come from a place of calmness, because risk has all sorts of meanings for us. People get very, very upset about some things, the language we use, the association of risk. Many people are triggered. I often nowadays, when I give talks like this, even though they're fairly general, very clinical, it is triggering for some people. Every one of you have had an experience of some sort of risk, and it's important that we make our judgments in a non-emotional way. And even though we say to our patients when they say, "Doctor, you're judging me," part of you is like, "Well, I'm not really judging you, but I really am actually." So it is a judgment, but it's important that we ourselves are not judgmental. So the other things to watch out for, because you as physicians have the ability to arrest people under the Mental Health Act. It's strong language, but we do. In fact, you have an obligation to fix things if you see things. People don't like hearing that we're agents for social control, but society and our governments have given us the authority to manage people's liberties through Mental Health Act or forensic systems. And we have to be very clear that this tendency towards, the custodial role leading to sadism, which is very well documented, to be able to help guard ourselves from that. And because we do know there's lots of research that comes up about how we feel when we have power over somebody. I'm not going to go, that's a whole other talk in and of itself, but we really have to guard about that. So if you do want the place to be safe, the environment that we're in should be less authoritarian and more democratic. This is not being a liberal giveaway to the patients. This is really recognizing they're also should be invested in their wellness and the safety of the places that they're in. And I think risk assessment, even though there's lots of science about that, could be described in terms of the human endeavor. It's not just a scientific experiment. I'll end with a slide like that I really end a lot of my talks with, which is something that I've helped try and put some cover on everything that we do, which is that if we can create a humane environment, that people are going to act out less violently. And I think we as clinicians have an obligation to do that.
Thank you, Dr. Chaimowitz, for sharing your experience and your wisdom.